Hello, everyone. Welcome to our show at this year's CR Arthritis event at the Canadian Rheumatology Association and Arthritis Health Profession Association annual meeting in Winnipeg. I'm Kelly Lenvoy, VP of Communications and Public Affairs. Today, we're lucky that we're being joined by Dr. Stephanie Garner, and she is a clinical assistant professor in the Department of Medicine and Rheumatology at the University of Calgary. She holds a master's degree in medical science from the University of Calgary in the area of models of care for patients with rheumatic disease. Dr. Garner, your presentation in Winnipeg is on updates in ANCA Associated vasculitis management through cases and collaboration. And to start off on what sounds like a fairly challenging or complicated subject area, maybe we can put at the first effort here, put a spotlight on vasculitis, and you can tell us what that disease is.
Yeah, so vasculitis is an autoimmune disease similar to rheumatoid arthritis or lupus, in which your body has developed antibodies or a reaction against itself. And in rheumatoid arthritis, you get antibodies or inflammation directed towards the lining of your joints, which causes joint swelling. And in vasculitis, you're getting inflammation directed against your blood vessels. And there are several different types of vasculitis. We usually look at what size of the blood vessels are involved or what the clinical features are, which whether it's affecting your heart or your lungs or your kidneys. And then we look at what antibodies are involved. So for example, in rheumatoid arthritis, we talk about the rheumatoid factor. In ANCA Associated vasculitis, it's a group of diseases for which we commonly see an ANCA, which is an anti-nuclear cytoplasmic antibody, which is a bit of a mouthful, but ANCA is what we use for short form, being positive in these patients. And we think it's that antibody which contributes to the autoimmune disease. And the inflammation of blood vessels, if you think blood vessels are all over your body, means that it can present in various ways. Usually ANCA-associated vasculitis affects the heart, the lungs, the kidneys, can affect your nerves, and it can affect your GI tract or your skin. So it does present with lots of different clinical features. And the kidneys are often affected, which is why one of the people joining our workshop, co-presenting with me, is Dr. Bryce Barr, who's a kidney specialist in Winnipeg.
A complex disease. And in Winnipeg, you're going to be talking about how patients can manage the disease. In terms of therapies, what are we looking at in terms of different types of therapies?
So the mainstay of therapy for vasculitis for years has been prednisone. And anyone who's been on prednisone will tell you it's a horrible drug. It works incredibly well, but the list of side effects is about as long as my arm. Weight gain, high blood pressure, diabetes, thin skin, easy bruising. It causes anxiety, difficulty sleeping. It works really well though, but it's kind of like taking a shotgun. So it fixes the problem quite quickly, but it causes a lot of harm. So one of the big shifts we've done over the past couple of years is looking at how we can use the least amount of prednisone safely to treat this disease. So a lot of that is involved, when we're using medications in combination with prednisone, we call them induction agents, and then we call them maintenance agents, kind of like in cancer care, where you're going to get treated aggressively with chemotherapy to get that cancer completely gone. And then we put you on something to make sure it doesn't come back. So it's the same thing with vasculitis. We hit the disease quite hard up front. We get all the inflammation to go away, and then we put you on a drug long term. So the prednisone is often used initially to put everything out, and then we use other drugs, something called cyclophosphamide, which is a chemo drug. We use it in much lower doses though, and rituximab, which is a biologic, also used initially in therapy. And now we're trying to think, okay, is there a way we can use these drugs so we can use less and less and less prednisone. And what's the least amount we can get away with? And that's been a big shift in vasculitis care for patients over the past 5 to 10 years or so.
That's interesting because I think patients sometimes hear that there are different guidelines in different countries. So I guess what I'm interested in is that this less is more paradigm shift that you're describing. Is Canada leading the way? Are we following maybe other countries in Europe or in the United States in terms of the recommended dose?
So we're lucky here in Canada, in one sense. So Dr. Mike Walsh, who published the PEXIVAS trial, which was one of the reasons why we now confidently, instead of giving people, huge doses of steroids for months, we now know that we can safely cut that in half. He was the primary investigator on that trial, and he's based here in Canada. He's at McMaster, so he's really influenced our practice and sort of led this from a Canadian perspective, and it has had influence across the world.
Hmm.
Unfortunately, though, in sort of we're leading there for sure and sort of being confident dropping our steroids. There's a new medication which Dr. Barr and I'm going to talk about a bit that's used as adjuvant therapy. It means it's used as an add-on. One of the main reasons they developed this medication was that they wanted to be able to get patients off prednisone right away. So rather than even just doing this lower dose of prednisone, you would completely stop prednisone up front using something to replace it. So that drug that was brought to market is called avacopan. And in Canada, unfortunately, it's not going to be covered by provincial plan. So for those of you who sort of are in health policy, you might know that when a drug gets approved by Health Canada, which avacopan has been approved by Health Canada, it then goes to a common drug review board, which has representation from across the provinces. And they look at the medication and they say, do we think this would benefit patients, and sort of at what cost? And unfortunately, much to the upset of the Patient Foundation in Canada and physicians caring for vasculitis patients, CADTH said that they wouldn't recommend it be funded. We've been lucky enough now still in Canada that we're able to access it through the company. They have an excellent compassionate care program, and there are some private insurers paying for it. But it is a little bit frustrating because our system is often compared to the NHS, which is the British system. And avacopan is covered by the sort of national pharmacare in England or over in the UK. The United States, most payers are paying for it also. So we're a little bit hamstrung here. We've been lucky because we've got the corporation here in Canada has been very supportive of use. But it is definitely some work there to be done in terms of seeing what options are to get it covered. Because that drug does allow us to stop steroids completely in a significant portion of patients with vasculitis.
There was an issue of Joint Health Insight that ACE published on the drug review and approval process. So that's something that our audience has seen us talk about in the last year. And certainly in terms of advocating for appropriate, timely coverage of arthritis medications, that's one of our missions at ACE. And this is something that we're talking to the provinces about currently. So I thank you for bringing that important point up.
I will say too, while I'm sort of advocating provincial access, so we use 2 medications in ANCA vasculitis to sort of put out the fire, get them under control initially. The first is cyclophosphamide, which is a really old drug. It is a chemo drug. It's still used in chemo protocols for malignancy. It's onerous for patients. It's an IV infusion. There's 10 infusions over 6 months. You need blood work with the infusion. And then the newer drug, which newer, I mean, came out in 2010. So we're now at, 14 years of experience with this medication, is rituximab. It works well. There's evidence to show it actually probably works better in certain patient populations than cyclophosphamide. But again, we're hamstrung by coverage. And, generic rituximab is cheaper than the brand name. Cyclophosphamide's old, but again, I think it's that, the payers aren't really looking at the whole picture. And, I have patients who have to drive 3 hours from a rural community to come in for their infusion. Then they have to drive back somewhere again to get their blood work the next week. And to do that 10 times over 6 months is quite labor intensive. You also need nursing staff to do the infusion, hospital chairs, access here for us right now in Calgary, getting someone a booking in day medicine for this. I'm phoning around. Do you want one of my kids? Really trying to get that versus rituximab is 2 infusions and that's it. We would do maintenance therapy in 6 months. So the care for vasculitis has really been a bit tricky, mainly because we're sorting out coverage. And I'm a rheumatologist. I'm used to drug coverage being a huge proportion of my job, but it's getting a little bit more complicated for this patient population, and it delays their access. Alberta Blue Cross takes a couple of weeks before they'll approve or decline something, which delays treatment. Versus if you look at practice in the United States or, as I said, the UK, rituximab is given sort of maybe 70% of the time, with cyclophosphamide 30% of the time. And our numbers are definitely not that high yet, predominantly because of access.
Now, in terms of therapies, there's also a type of therapy for vasculitis, maintenance therapies. How do you determine the most appropriate maintenance therapy for a patient?
Yeah, and it's a bit tricky because we have a lot of, when we do our clinical trials, we usually look at 2 years. We treat them for 2 years and then that's it. And then there's some trials where they're treating them for 2 years and now they're following them for 4 years because we know the risk of relapse in this patient population where the disease comes back is actually quite high, and it can be up to 70% over a 5-year period.
Wow.
And our traditional treatment paradigms have been that you treat for 2 years and then you see what happens. But there's a lot of evidence that at least maybe half of patients are going to relapse in that next 2 years. So we're really trying to figure out who are the patients we should be putting on sort of longer term maintenance, and then what's the best drug. And this does again come down to coverage. It looks like rituximab is probably, and that's the infusion, it's once every 6 months. That probably is the best in terms of preventing relapse. Again, it's a negotiation of coverage depending where you are in Canada. You may or may not have access. If you have private insurance, generally that's a bit better than the public insurance. Azathioprine is our other option, but it doesn't work quite as well as rituximab. So when we're trying to make a case, being sort of a steward of the healthcare system, often it's these patients who have risk factors. We kind of have a somewhat idea of what puts you at increased risk of having a flare. So if you've got granulomatosis with polyangiitis, which is one type of ANCA vasculitis that affects the upper respiratory tract, we know you're at increased risk of flare. So we try and use what we can to predict who we really should advocate for getting rituximab versus azathioprine, which are sort of the 2 mainstays of treatment. But it really heavily depends where you are in Canada and what your insurance coverage is like, whether it be the public plan or you've got private insurance, what I can get covered.
Yeah. I mean, that's often a gap with models of care for all the inflammatory arthritis diseases. And it's certainly not acceptable that currently there's no standard of care, that where you live, and often that means the farther you are away from the southern urban centers, the more challenging it is to live with your disease. And certainly it's something, again, that's a real focus for ACE. Final question for us today, Dr. Garner, is around, I mean, you've described, again, we'll say described as a very complex disease. There are multiple members on a patient's healthcare team when you're dealing with a complex disease like vasculitis. How is it important that the different members of that team, the different specialties, um, follow an interdisciplinary kind of team-based approach to the care of the patient?
I was really lucky in my training. I trained at McMaster, and one of
Hmm.
the key things that sort of had drawn me to doing some of my training there was the fact that they ran these collaborative clinics. And I think it's a real sort of it's that idea of you don't know what you don't know often. And in doing these clinics as part of my training and then as faculty, it was either you know, a rheumatologist and a kidney specialist, a rheumatologist, a kidney specialist, and a lung specialist, or a rheumatologist and a lung specialist. And one of the nice things about that was that we often need to make decisions in the moment. And I'm an expert in immunosuppression. I'm an expert in arthritis. But I don't know the nuances of the lungs or the nuances of the kidneys. So one of the things Dr. Barr is going to talk about at our talk is like, when do you worry about blood and protein in the urine in this disease? And what are the nuances of that? And one of the things I learned doing those clinics is I learned a lot about how to collaborate and how to talk to other specialists. I learned the importance of having that relationship with the other specialists so that if there was a concern, I could talk to them. We're not sending these consult notes back and forth that take, a week or a month to go back, or we're not dumping it on the patient in the sense, you know, when you're at the appointment with your respirologist, your lung specialist, can you ask them what they think of this? And it also kind of sends a clear message to the patient. So the collaboration on this is really important. Um, I've really enjoyed it. I do a clinic with a kidney specialist here at the University of Calgary. And I think it provides better patient care because I know what my colleague needs in terms of testing. So if I'm doing blood work, I know they want a urinalysis and a protein to creatinine ratio. I know the lung specialist, if the patient's in the building seeing me, they might want a chest x-ray and I'm going to do that. So I think this really close collaboration with our colleagues really is important. It improves communication and I think it directly benefits patient care. But you really have to get a good sense of what the other specialist wants to provide this holistic care and a disease that can affect, many different organ systems. When medicine, we're kind of used to staying in our box, the cardiologists like the heart, kidney specialists like the kidneys. So working with people who, can kind of look at patients holistically and have those strong communication skills is really important for patients.
That's really an important point and perspective for our audience, especially those living with vasculitis. Um, I think one of the key takeaways from today is, given the complex nature of the disease, how important it is that patients keep informed, um, keep open, regular lines of communication with their healthcare team, and being able to have a constructive, positive conversation with them as their disease evolves, but so does the treatment and therapies for it. So that treatment plan is not something static, but something that probably is ever changing. Really important for patients to keep informed. And we thank you, Dr. Garner, for joining us today, talking about a really important subject area. And and thank you, everyone, for joining us today on the show. Look forward to seeing you again as we bring you more updates and more interviews with leaders like Dr. Garner.